This conference will now be recorded.
Hi, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Monday, July 21st, 2025. I'm Len Sierra. I'll be moderating today with my fellow moderators, Rick, Dr. John, and Ben, and all of you wonderful people who are well informed. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. And we want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. So, Rick, any introductory remarks?
None right now, thank you.
Okay.
So, one thing, we would all like to wish Miss Alexa a speedy recovery. She had some surgery today, and we hope the biopsy is going to come out very benign. So we all keep her in our thoughts.
Okay, thanks for letting us know. Well, let's start with Richard Fisk, who we didn't have a chance to speak last week. So go ahead, Richard.
Okay, short update and a couple of questions. I finished ADT last October, and my PSA remains undetectable. Serum testosterone was 60 in January, and last week was 298. So that's the low end of normal. But my free testosterone is 1.0 versus a 6.1 minimum. And I'm curious what that really means. The massive fatigue that I had when I was in ADT, fatigue and weakness persists even though I'm exercising, and it's not sleepiness. So I'd be curious as to the hive mind's thoughts on that. And the other question I have is protein sources, effective protein sources, and especially is low-fat dairy harmful?
So well, let's see. Richard, when did you go on drug holiday?
October 27th.
Oh, okay.
Last October.
And how long were you on hormonal therapy?
24 months.
4 months?
Okay, Len, it wasn't a drug holiday because Richard Fisk, that was his initial treatment, kind of like my initial treatment.
I'm finished with treatment.
That was his treatment. So this is different from a drug holiday. That was his same as me. I got 28 months.
Okay. So, well, maybe Rick can answer this. Were you feeling fatigue even after you stopped your 28 months of hormonal therapy, Rick?
Yeah. I mean, well, like it's a good question. I mean, like Richard, I was exercising all of the time, but it probably took me a good 6 to 9 months to get back. But my suspicion in Richard's case is that it relates somehow to the issues he had in coming off his prednisone. And I don't know enough about adrenals and endocrine to know if you didn't come off right, which was Richard's case, how long it takes to get back to normal. I don't know. Gary Peters, how long did it take you to get back to feeling normal after you came off in not quite the best way?
Unfortunately, I'm not normal yet. It's been it's been 2 years.
We had thought that the issue was prednisone, but I've had a cortisol check. My cortisol is normal.
Yeah,
And
that's I when I was emailing with you, Richard, I noted that your test is normal.
so the cortisol is normal. I think that I'm clear of any residual prednisone issues. So
Dr.
that
John, would you agree with would you agree with that?
Yes, I think so. I think you're pretty much kind of on track. Weren't you on Lupron, and wasn't it a fairly long shot? How long? How? What Lupron shot did you have back then?
I had 3-month Lupron shots, and I timed the last one to have a 1-month Lupron shot,
Oh,
so
you
that
did.
it terminated on the same day I stopped my abiraterone.
Oh, I see. Okay. I don't know. It's a long time, but it's probably not much longer than typical. I mean, some of us like me never recover the testosterone. Some of us like Gary never recover the cortisol. You have uh, starting to get a decent testosterone level, but as you mentioned, a fairly low amount of it is free testosterone. I think that you're still in the recovering time, and I don't think you've stalled out or have too much to worry about. It just takes a long time after 2 years on ADT.
What does a low free testosterone mean?
A lot of the chemicals that are transported around our blood are transported bound to serum proteins like albumin, little trucks that carry them around basically.
Hmm.
Now, a hormone or any other chemical cannot interact with a cell if it's in its bound form. It's like it's inside the truck. So the free form is just a pure bare testosterone molecule floating around in the blood. So yours are not that high. Uh, I don't think you're by any means saturated with testosterone at this point. So um, I would expect further gradual recovery over the next few months, I think is what I would predict. Um, if there isn't any at all uh, over the next few months, we can talk again, or you can see an endocrinologist.
Okay. To talk about supplemental testosterone would be playing with fire, right?
Well, it's a good question. There are a handful of us in this group um, who have gone off our ADT and never recovered our testosterone and have been offered testosterone replacement by our doctors, or at least read about the idea of testosterone replacement. We've looked into it together, and we have been reassured by the fact that there's very little convincing evidence that it's like pouring gasoline on the fire. But we are all four of us too chicken to put it to the test.
Okay.
So I could go on supplemental testosterone according to my oncologist, and from his point of view, okay, your PSA goes up, we just take you off and start you back on treatment. But I wouldn't not think about testosterone replacement, certainly at this point for you.
Okay, so it's too soon to even consider it.
I think so, yes. I think you're
Okay.
still building up, and your next testosterone might be a little higher.
All right. I will keep tracking that.
Rick,
And is
go ahead.
Yeah, I did take supplementary testosterone after about, I would say it was a year to a year and a half, where I felt my testosterone was kind of low and wasn't coming back more. I wouldn't say it did me much good. I didn't feel any benefit from it. I stopped after a few months, but then eventually my testosterone did come back. It probably took it probably took a good 2 years to get back to my baseline level. So now I was a lot younger, and that's another thing. I mean, as young and healthy as you look, Richard, your age is a factor, and it
Understood.
and it will compromise. It will compromise you. I mean, yeah, you're close to 20 years older than I was when I was dealing with this. So the other
Yeah.
thing I would say is that if you are considering um, supplementary testosterone, I would wait. If it were me, I'd probably wait a good 12 months to make sure that, I had solid consolidation of my situation.
Understood. Last question is um, low fat dairy as a protein source bad? I know high fat is.
Yeah, I think I remember reading that in the Prostate Cancer Foundation dietary guidelines. They recommended against dairy products. And some time ago, not even that long ago, I looked into that, and there was a reason for it, which I have since forgotten. But if you want to, well, first of all, if anyone else here knows why Prostate Cancer Foundation was recommending against dairy products
Yeah,
in general, please let us know. Let's
well,
see, Gary, you
yeah. I
had,
mean, it's
I,
controversial. It's really controversial, and so
yeah,
traditionally go back, and we had this discussion actually in the one of the groups last week. I
yeah,
forget which one. Wasn't
I think
this
it
one
was
about?
low intermediate. Yeah.
Yeah, about the China study. So the China study by T. Colin Campbell is a really good book to read if you want to know more about the impact of protein. However, that book is highly, highly controversial. A lot of people don't agree with it. But the thrust of that book is that red meat protein and high protein dairy products are not good. Now, ironically, skim milk is actually worse than low fat milk because the protein content in skim milk is higher than it is in low fat milk because they add back whey to give some body to the milk, and the whey is like concentrated protein. So what we tend to think, and there is a lot of evidence around this, is that certain proteins like red meats and high fat dairy are not good. Um, Low fat dairy, probably in moderation. Eggs um, were thought not to be good, but now we're not so sure. So again, eggs in moderation are fine. I think Dr. John probably has a comment on eggs. Um, but by and large, it's best to avoid dairy. I mean, I eat maybe a slice of cheese a day, or at most two slices. Some days none at all. Um, I use oat based. Um, I won't call it milk, but oat, whatever you want to call it, instead of dairy milk.
Hmm.
I do use half and half in my coffee, but it's very much in moderation. I'm sure there's other people who have comments on this, Lynn.
yeah. We have
I'm just looking for
Gary
protein
and
source.
Gary and Ben have their hands up. So first Gary, then Ben.
I had actually had a chance to ask that very question of Dr. Stacy Loeb, and she echoed pretty much what Rick has said. She said that she doesn't advise, she doesn't encourage dairy, but does not prohibit it in her view. But she said if you're going to have dairy, low fat or skim, she included skim, is better than full fat.
Okay.
That was her take.
Ben, go ahead.
So what I remember of that recommendation, there may be more information subsequently, but that it was more narrowly defined than dairy, that it was whole milk, that they knew about whole milk and could extrapolate that it might be related to fat, but it was not a prohibition of dairy, as I recall.
And regarding eggs, I remember now reading that the theory behind why you shouldn't be eating eggs if you have prostate cancer is that the yolks contain a lot of choline, which, as we know, is a nice food source for prostate cancer cells. That's why they have the C11 choline scan. It's rapidly taken up by cancer cells. So at least for egg yolks, definitely not a good idea. And let's see, we have one more hand here. Jeff, go ahead.
Boom. Oh, I see. Hear me? Okay.
Let's come back. Let's come back to Jeff. He's got to
All
sort
right,
out his
I
audio.
think I got it now. Can you hear me?
Yeah, go ahead.
Yes.
All right. I've just been looking up whey in non-fat milk, and it's not true. Ordinary non-fat or skim milk sold as a beverage does not contain whey. Whey is a protein concentrate, may be blended with non-fat milk powder to adjust protein content, but it is not used in regular milk. I've been searching this since last week when it was brought up, and I could not find a single incident in which it's reported. So that is just plain not true that whey is put into regular milk. It is not. It's just put into non-fat milk that in a powder form.
Right. So let me clarify what I said. What I said was non-fat milk is not as healthy as low-fat milk because whey is added to non-fat milk.
But it
Whey is
isn't.
added to non-fat milk. What that?
No,
It's
it is
not
not
added.
added. They don't add it. It specifically says, and I've looked this up, Rick, they do not add whey to skim or non-fat milk sold as a beverage. It's only done with non-fat milk powder. I looked it up last week. I could not find it. If you look it up, you will not be able to find it. And the thing
Well,
is, they only take out the fat. That's specifically what they say. They strictly take out the fat, and that's it.
okay.
For
Well,
non-fat milk.
that was the argument in an article many years ago. I'm not going to go back look for the article, but that was what came out of that article. So I can only tell you that's what I learned, and I'm going back to probably 2011 or 2012. So at that time, the article stated that non-fat, and if they actually printed this up in the some of you may remember that Us Two used to have I don't know if they still do, if Zero puts it out, but they used to have a weekly printed reminder. And it was an article that appeared in one of those weekly printed reminders many years ago. Jeff may be right now, but I can only tell you that at that time, that's what it said.
Dr.
Probably
Jack,
before most
jump
of
in.
you were done. Go ahead, Jack.
Yeah, choline, when I had my C11 choline scan back in 2018 at Mayo, I questioned that because I eat a lot of broccoli. And I said, should I avoid broccoli now since choline, is so absorbed by the prostate? They told me, no, 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 no. You don't have to worry about dietary choline affecting your prostate cancer. So either they knew what they were talking about, or they didn't know what they were talking about. But the choline is in everything, in chicken, poultry, eggs, beef. Choline's in so much of the food that we eat. If I had to stop and think of the amount of choline I'm eating and how that correlates with my prostate cancer, I'd be eating nothing but beans. So I think I think we have to look into that before we become frightened of eating choline, especially broccoli. It's supposed to be so healthy.
Yeah, it's true.
And
Well,
can I just add, because just for kicks, I said, is there whey in skim milk? And the answer comes back, yes. Skim milk does contain whey protein along with casein. Skim milk is essentially whole milk with the fat removed, and the protein content remains similar. In milk, proteins are roughly 80% casein and 20% whey. Now, here's where I think I am wrong, is that it may not be that and I don't know that they actually add whey back in, but the amount of whey concentrate in skim milk is much higher than the amount of whey concentrate in other types of milk. So you're getting more whey protein per glass in skim milk than you are in other types of milk. And that might be the compromise between Jeff and myself, in that it's just higher in whey protein than other types of milk.
Let's see, is he still here? Yeah, he is.
Richard, okay if we move on?
Oh, that's
Yeah. Well, one last bit. Best protein source then.
Well, I would say, and then again, other people should chime in. I would say that the best protein source is vegetable protein, of which there are many sources. I would sort of start with legumes, which are very high in protein, if you can tolerate them. Because again, especially as you get older, it's harder and harder to tolerate legume. I love them, but they don't like me. So I've got to be careful. There is protein in certain green vegetables. There's plenty of protein. I mean, I do recommend that you listen again to Dr. Loeb's webinar that she did for us, because I think she covers it in that. I'll put it in the chat window in a minute. Also, look in the PCF dietary book and the UCSF dietary book, and all of those. In terms of animal protein, best would be fish that is high in omega-3 content. So the oily fish like salmon, mackerel, etc.
Thank you very much.
All right. Let's see. We also missed Mark Valens from last week. So go ahead, Mark.
Oh, just a quick update. So on Friday, I got the 9th of my scans that I've had in 2 weeks, all kinds of different scans, and they all confirm the cancer spread pretty much all up and down my spine and into my hip bones and into my liver and the adrenal glands. And so I talked to Dr. Agarwal at UCSF tomorrow. That looks like the best treatment option for me is cabazitaxel and carboplatin. But we'll see if Dr. Agarwal has any other ideas. Yeah, he's involved in some scans, some trials, but I'm not sure if I qualify for any of them. But I'll be asking about that. But it's not getting easier. I'm having more pain, having more trouble getting around. So I hope I can get on some treatment that gives me a bit of a break. But that's it for now.
Mark, sorry to hear this. Are you able to manage the pain? And if
So
so,
far,
how?
yeah, yeah,
Yeah.
and I'm doing my best to do it without narcotics. So I've
Uh,
got and I got an
I
acetaminophen and ibuprofen protocol going that's actually helping.
Well, yes, but I am going to chip in because Mark has a high tolerance for pain, and it's not easy. I mean, he told me earlier on today. I'm sure you don't mind me sharing this, that it's hard to sit in the car for 2 hours to take a trip, and so there's something that isn't right there. He has, at our instigation, an appointment with Symptom Management Service, which is palliative care service at UCSF on the 31st. And I've written to Dr. Rabo, who we know quite well at SMS, and to see if we can bring that forward. I mean, I want to get Mark to a point where um, he's comfortable enough that he can get in the car and go over the mountains to his ranch if he really wants to, because I think he should be enjoying that. That's my humble opinion. He didn't say that to me, but I'd like to see him enjoying that. I would like to. I'd like to bring. This is a really important topic for everybody here. I'd like to bring in Dr. John, because most of you know Dr. John as a psychiatrist, but his area of specialty was actually pain and addiction. And I think that we are, and probably rightly so, very leery of going on anything too strong. But at the same time, I think that if it's managed well and properly, and it's managed for um, critical pain, for breakthrough pain, that we can use something stronger. John, can you say a few words about using pain meds?
Yeah, yeah. Um, First, I would like to say, being not being any expert in the matter, but it does seem like the chemo combination that they have in mind for you is a logical next step. From what I understand, that makes sense, and people have responded to that combination at this stage. But yeah, you shouldn't really have to tolerate very much pain. Pain can be addressed in extreme situations with narcotics, and so you never have to be in terrible pain. But there's also a whole variety of different medications and treatments that are good for pain. Anticonvulsants are used for pain. Acupuncture is used for pain. Motrin and Tylenol are used for pain. Uh, there are various kinds of nerve blocks. There's local treatment, systemic treatment. So if the palliative care people aren't really up on it, which would surprise me very much, but if they're not, then find a pain center. They know all the tricks, and don't be discouraged if one pain method doesn't work, because you have to sometimes add them together. I mean, people used to scoff at me when I would say, "Well, what about Tylenol?" Because it's like M&Ms to them, but sometimes if you take 5 or 10% of your pain away with something simple like Tylenol, you might go from unbearable to bearable. Add things together in combination.
Great, thanks.
There are behavioral treatments for pain as well, cognitive behavior therapies and things like that. So look into the whole spectrum of things that can be done for pain. Don't put up
Okay.
with a lot of it.
Good advice. Thanks, Dr. John. I don't suppose there are any methods of administration with opiates that could be less prone to serious constipation. So, in other words, if it's oral or injection or whatever, um, is the risk of constipation the same for any mode of administration?
Yeah, having an injectable opiate with the idea that maybe it won't be in the GI tract and cause constipation doesn't really work because opiates in the bloodstream are also quite capable of paralyzing the intestines. So when people do use opiates, they have to be on um, a bowel regimen. Just like with pain, treatments for constipation start here, and then you go to this and this and this and this, and you combine and so somebody that's really familiar with the bowel regimen for constipation can take you through the different levels and make sure you don't get severely constipated. This comes up a lot in drug addiction because of people on methadone maintenance, for example.
Okay, thanks. Mark, anything more?
I'll
Just a
know a
sec.
lot more tomorrow after talking to Dr. Agwal, and then I'm scheduled for a biopsy on Friday. So by next week, I should be more informed.
It'd be good to hear from you again next week and see what these two things resulted in, although you might not have biopsy results yet.
Yeah.
How long has it been since you got that biopsy that said that there was no neuroendocrine disease
That
or
was
no?
like November or
Okay, November.
back then, yeah.
Okay, thank you.
Len, can you hear me? I'm having some microphone problems. Am I coming
I
through
can
now?
hear you. I can
Right,
hear
great.
you.
Okay,
Yeah.
Dr. John, I just read this past week, I didn't make a note of what it was, of some sort of drug that can be prescribed with with opiates to help with constipation. Does that ring a bell with you?
Yes, it does ring a bell, but I can't bring the name out of my memory either.
Okay.
Uh,
Anybody
if
know?
I think it's tramadol, if I remember correctly. It may be
Well,
tramadol.
tramadol is really an opiate and can cause
Yeah,
constipation itself, but probably less
much
so, but it's
less so.
also
Right.
less potent, right, Jack?
Yeah, that's right.
I'll look and see if I can find it.
Mark, where are they going to biopsy?
Ah, good
That's
point.
waiting to find out tomorrow.
Okay.
We'll look at all the scans but the liver, soft tissue is the easiest. So I've got both liver and adrenals.
Oh,
I don't know if they'll actually try any bone itself, but
So bone would be the last preference. You're better
Liver.
off with soft tissue and then doing a blood. Where's your PSA is probably quite high right now, isn't it?
oh, it's almost up to 1 by now.
Oh, that's right. You don't make it, but that's right. But there's probably enough in your blood, so it should be number one soft tissue, number two blood, and number three bone. The reason we don't like bone is because you have to macerate the bone, break it down in order to analyze the bone, and that maceration process may cause some distortion. Ben, I'm curious if you have any input on where a biopsy might come from. I mean, how would you say compare a liver biopsy to an adrenal biopsy? Any thoughts on that?
nothing on that, but certainly if it's neuroendocrine, the liver is probably where you'll find it.
From a medical point of view, liver biopsy is relatively easy to do. I even did several of them as a medical student. That's how easy it is compared to an adrenal or a bone biopsy. So I think, a good gastroenterologist can readily, you know, using whatever guide they're going to use, MRI, can go in there and do a liver biopsy, and it's there's no pain. It's easy, it's soft, it's quick, and they go in through, you know, under the rib cage or through the rib cage.
But I think Rick's got a good idea to do both the liquid biopsy as well as a tissue biopsy, being that you have so many lesions. um, you could take a tissue biopsy that only has certain mutations in it that are not present elsewhere, and vice versa. So the liquid biopsy can pick up mutations being shed from tumor cells anywhere in the body.
Yep.
Okay, Kang, you are up next.
Thank you, Lynn. Update, I visited my doctor, Matthew, from MSK last Thursday. I guess my condition is the PSMA scan gives information, evidence of lesions. One is in the pelvic lymph node. The other one is the ureter, distal ureter. They're all in the right side. I asked Dr. McHugh if they are related. I guess his answer is he couldn't be sure. Usually, rarely, prostate cancer will show up in the ureter. It could be a bladder disease issue, could be bladder, but without further investigation, it's difficult to know. I asked about the biopsy. He said has to do MRI first to see whether it can be biopsiable, because it could be dangerous. They just have to because they don't know whether it's easy to biopsy. I thought it's easy. Usually, it's easier to do the biopsy in the lymph nodes, but I don't know enough. He said there will be an MRI, but he didn't order it. He will prescribe it, but I don't know why he didn't order it that day. He said Tuesday. If it's not tomorrow, that will be next Tuesday. There will be a tumor board meeting. He will bring up my case, and I don't know. Maybe he'll have a better idea about what to do from the tumor board meeting. I thought prescribe an MRI to the pelvic lymph nodes probably doesn't really need a. I don't know, right? Why you have to go to a tumor board meeting to decide? Maybe my case is complicated. Again, he bring up a possible options for a trial. He mentioned two trials. One is a CAR T. He said it's brand new. It's like just opened up 2 weeks ago. I asked about the phase. He said it's phase one. And the other one is the other trial is I cannot remember the name. He said it's sort of like Pluvicto, but it's not Pluvicto. Pluvicto is
Was it actinium?
Something like that, because that words actinium, that rang my bell.
Yeah.
He said it's milder, it's newer. He said in my case, chemo and Pluvicto are all too much, just because the PSMA couldn't detect any disease in other parts of my my body. He said Pluvicto is like if you have multiple poly spot, Pluvicto is an okay option. But you don't have that, so Pluvicto is too much. But the one Len just mentioned, titanium. He said that one's milder, So that's an option. I asked about the phase. He mentioned it's probably, yeah, I could, my memory is like one is phase 1, one is phase 1.5. He said there are other options for trial, but it's too early to say right now because uh, a spot radiation is still an option, and so I guess all will after they could see the MRI to the um lymph node, pelvic lymph node, they will have a decision. What I I can write a note from my charts that I will take. I'm willing to take risk to for the any the risk that's associated with the biopsy, even it could be even it's not easy to do, but there's no MRI, so all is just theoretically a possibility. Um, I guess I'm going to push him. I don't know why he's so laid back, but not order MRI. Even that day, right? That was Thursday, 17th. I mean, could he just order MRI that day? Because it will be needed sooner or later, eventually. Yeah, that's about it's almost like a good news that he said, well, chemo and the Pluvicto is too much, given the evidence we have. But again, my PSA was 39 on the 2nd of July, which is about 3 weeks ago. Like giving it today. Well, he didn't do a PSA blood draw that day in the visit. 3 weeks later, I could easily be 50 or I don't know, under 60. So PSA is going up fast, and the SUV on the pelvic node, lymph node is 40, and distal ureter is 25. So it's like one side the numbers are high, the other side is chemo and Pluvicto is too much. It's like good news and bad news are all there.
You can send me the two clinical trials, Kang, and I'll take a look at it.
All right. Yeah, he didn't. He said it's still too early. He said that once we kind of decided whether to go with it, and then he will give me the name of the trial. I asked if there are trials which are phase 3. There is one, which is the one that's involved docetaxel, and that was the one Mount Sinai was offered back half a year ago. Lorigerlimab. It's like it's a phase 2 trial, but it's phase 3 now. But it's involved either you have docetaxel and a placebo, or you have a docetaxel with the drug. Except docetaxel is too much in your case, so he wouldn't recommend that, even if that's phase 3. That's right.
If you could put that second drug into the chat box so we could see what it is. I couldn't quite understand what you were saying, unless someone else understood it.
It's okay. I'll write it.
Yeah, it's a quick question.
Meanwhile, Jack, you have a question, a comment?
Yeah, I wanted to know, did he say distal ureter, distal, D-I-S-T-A-L? Did you say distal ureter? Okay.
Distal ureter.
Distal, D-I-S-T-A-L? Is that what you said?
Yeah, distal ureter. Yeah.
All right, so that's right next to your bladder. So it's contiguous with your prostate. So there's a high probability that it's a contiguous spread from the prostate right to the ureter from the prostate and the bladder in that area. So it's I didn't hear that before. I thought it could be proximal or mid ureter, where it's highly unlikely or very rare to have a prostate spread. So Yeah, they could do a ureteroscope, and they can go up there and they can do a biopsy quite
That's what he
easily.
said.
Yeah,
Dr. He did mention the scope, ureteroscope. He didn't mention that. Yes, he
he
did
did.
mention.
He
He
did or
mentioned
didn't.
that he didn't order it yet.
Yeah, it's a thought.
Whoops. Oh, it's not going.
Oh, that sounds familiar, Rick. Didn't somebody look into that recently? That
What are you
drug that,
looking at? The drug
that
that
Kang,
Gary.
It's
Kang,
from
Kang,
Uh,
Macrogenics.
uh, I'm not sure. I'm not. I don't want to say, Lena. I'm not sure. But what
okay,
I
okay.
wanted to say, what I wanted to say to Kang is that I I really don't think we should even be discussing trials until we know what where the cancer is and what it is. Because yes, it could be prostate cancer, but it could be something else that we're looking at in the distal ureter. And so, and if what all we're looking at, if that's some sort of false positive in the distal ureter, and what we do have is just a spot that we could radiate in the nodes, it's a whole different situation. So we're tying ourselves up in CAR-Ts and Origalimab and this and that and the other. We don't even know yet. I would set it all aside because what we're doing right now is running down rabbit holes. And I don't think it's a good use of anybody's time, even Len's, to send him the trials. The first thing we've got to do is get the right diagnosis. And once we have the right diagnosis, then we can talk about trials.
Yeah, by the way, Kang didn't mention, but he did get results back from Foundation Medicine's ctDNA, and it was absolutely clean. Nothing there.
And he wasn't sure whether biopsy is necessary or whether it's too difficult to do it. I write a note from my chart today. I said I'll go with any risk. I don't know how risky can it be to the lymph node. Is it supposed to be easier to biopsy the lymph node? But
It depends where the lymph node is.
Yeah.
There's so many lymph nodes. Yes, some are easy to biopsy, others are not.
Yeah.
You can't make a statement that it's easier to biopsy the lymph nodes. We don't know where they are. Some lymph nodes are in really difficult places that they cannot get to.
That's probably what he means. That's. I mean, we all have to, after the MRI, to the pelvic section.
I mean, we've got to go step by step, and we're getting way too far ahead of ourselves because we haven't done the MRI. We don't know what can be biopsied or not. As Dr. Jack very correctly mentioned, and McHugh has observed, we probably could get to that distal ureter using some equipment. But right now, we're not there yet, and we're already talking about all these investigational trials. Why?
I don't know.
You're push. I suspect, and I'm not sure, and you can tell me, but it may be because you're pushing Dr. McHugh about what trials are available. He feels that he needs to respond, and I don't think you should be pushing him on the trials right now. We should be pushing him on what is it that we need to treat, and then we can decide, is trial right, or is some type of standard of care correct?
I didn't push for the trial. He bring it up first thing. Yeah.
I'm sorry, I stand corrected.
I have the. It's like what Dr. Saw from Mount Sinai is the same way of promoting the trial.
I get it. They're
They're
all doing that.
Yeah.
But then your job at that point is to say, why are we talking about trials? So either way, if you didn't ask for it, and God bless you for not asking for it, your job is, why are we talking about trials, Dr. McHugh, when we don't even know what we got to treat? Shouldn't we wait and see to what we got to treat, and then we can talk about trials? Because we're getting ahead of ourselves.
I will be able to see that if I were you. I didn't see it because I'm not you. It's that's a difference. I mean, I guess I will have a better idea next time I visit him. I said, so I'm just gonna wait. He said, well, Tuesday, if it's not this coming Tuesday, that'll be next Tuesday. He'll bring my case to the tumor board and then go from there. I thought he could just order the MRI right that day in the last visit, which is Thursday, but I guess he wanted to show it in the tumor board and then decide whether the MRI. Well, don't you think he could have just ordered the MRI that day? I mean, it will be evidence and useful evidence to be used one way or the other, sooner or later. But it didn't happen. I pushed for it today. I said I would rather have the MRI to the pelvic area, also the scope that Jack mentioned and McHugh also mentioned during the visit. I said I would rather have that test sooner than later.
All right, Kang. We're going to have to move on, but keep us posted on what tests they do and how soon they do them.
Yeah. Thank you so much. Thank you.
Okay. Alan Moskowitz, you are up next.
Okay, just a quick update. I reported before I have a recurrent prostate cancer, basically now in the form of lung nodules. They're still very small. The doubling time for my PSA has slowed down. I'm up to 1.1, and that's gone up basically since the end of 2022 when I finished a year of hormone therapy. Now, I'll just mention to Rick, I did see Chuck Ryan at my first visit at Sloan Kettering out here in New Jersey. Very happy with him. He mentioned your name and he gave me extra time, I think, to visit with him. He knows some of my other doctors very well. And so I was overall happy. He grasped my situation pretty quickly. And he did say that lung nodules tend to respond very well to hormone therapy. And he said if your doubling time stays like it is, which is something around 14 to 16 months, he said I should be good for another couple of years at least before I need further treatment. So I was very happy with that. I have another appointment with him in roughly in 6 months, and we'll go from there. So all in all, a very convenient, 30 minutes away, better than a whole day expedition into Manhattan. Thanks for that recommendation.
So let me just clarify. So basically, Chuck said, yes, there's a small lung nodule, but we're going to watch it for a while and we're not going to put you on hormone therapy
That's
right
correct.
away.
No hormone therapy yet. The doubling time, as long as it stays above 9 months or so, he wasn't concerned about it. I mean, frankly, I have no reason to think that doubling time should change significantly since the last time, since before I had ADT. My doubling time before my first round in 2016 was about 15 or 16 months. And so, of course, we expect doubling times perhaps to decrease and over time, but right now it seems to be hovering in the same place. So, I'm in good shape.
Alan, did you say you saw Chuck Ryan in New Jersey?
Yes. He's in New Jersey now, 1 day a week in their Monmouth facility, which is basically Homedale. And so I've been waiting until I get a top-notch doctor there, and to avoid televisits or to avoid going into the city. And it was, last fall he joined. I think he took over Dr. Scher's position. And so he's got a full caseload. He has patients 2 days a week, I believe, in Manhattan and 1 day a week in New Jersey. So, yeah,
Howard Scher moved on. He's no longer with MSK.
I think if I have that correct, yeah, he might have. I don't know if he retired or left. I can't be
No.
positive if I heard the name right, but I think that was correct. He said he said it very matter of factly, as if it
So
was well known.
I don't think Scher's left. I think he's just reducing his caseload, and I don't believe Chuck has come in as head of the department.
No, I don't believe he's had. Nope.
I think he's just there as a consulting oncologist, but he may have taken over a bunch of
Some of his cases. That was my
cases.
impression. Yes, most definitely. Okay.
Jack, you have your hand up.
Yeah. Can I ask you a question? I don't know if I heard correctly. You took a holiday. Your PSA went down to 0. Now it's 1.1. Is that what you're saying?
Yeah, I have my last year of ADT ended in
Right.
2022, and since then it's gone up to 1.1.
Okay, now, and your PSMA scan in the interim on the way up to 1.1 was what? It showed little
It
pulmonary.
showed when I had the scan done, it was, I'd have to look back. It might have been 0.6 or something like that. And they wanted to do it. And I said, fine. And there's some very tiny, they call them punctate nodules. But it's nowhere else. I'm unusual.
Yeah, I know. I have the same thing. I'm just wondering why you didn't. Nobody suggested SBRT or proton or anything.
I already had radiation once. I didn't have it in the lungs, but I heard from my original oncologist was too much collateral damage. It's very near my heart, and he said it's just. He says in your case, it's just not worth the risk.
Oh, it's on the left side or rather than the right side?
Yes. Yep.
Oh. Okay.
Yeah.
Okay. Thank you, Alan.
Yep.
Here we go from Alan to Elaine.
Yes, thank you, Len.
Yeah, you're
So,
welcome.
quick update. I did see my general oncologist last Wednesday. I'm on apalutamide. I don't think I pronounced this properly.
Apalutamide?
Yeah. And there's already a genetic testing that has been done on my original 2015 biopsy samples that they were able to rescue. I don't have the results yet, but I'm going to see the doctor every month. She's going to be monitoring my PSA levels, of course, but also testosterone, all sorts of other markers. And so, again, as I said, I'm going to meet with her every month. And I have this week a bone density scan and a CT scan that are going to take place, just to kind of to establish a baseline measurement. And that's the update I have. I feel that I'm in a good hands. And there was one thing that she said, I think it was not lightly said, that a patient like me, I can survive a decade or maybe possibly 2 decades. So that made me feel less anxious than before.
Oh, great news.
Didn't Dr. John tell you that? Dr. John, you're slipping up.
No, I didn't, but he said that everything sounds good. So,
okay. I mean, the only thing that concerns me, Ella, is that I wouldn't be, if it were me, I wouldn't want 10-year-old tissue sequenced.
okay.
Because it's too far. No, it doesn't have anything to do with the quality of the tissue. They can sequence it. But prostate cancer changes over time. And what might be true 10 years ago would not be true today.
Okay.
So to me, from what I know, and this isn't medical advice, but I would tell them don't even bother with 10-year-old tissue. If we're going to go through that and go to the expense, we've got to get something much newer to test.
I can ask for that, for not a problem. Yeah. Thank you.
Two of your lymph nodes are inguinal, which means that they're probably fairly accessible.
Okay. Okay, I'll keep that in mind too. Thank you, Dr.
How's your
John.
PSA now?
I don't know actually. I'm having the PSA tested tomorrow because I have an exam with my regular doctor tomorrow, and
great.
also a heart exam.
Oh, good. That's really good.
Yeah.
Tell them you're on ADT, of course. That's going to be
Yeah.
significant for the
Yeah.
heart doctor.
Yeah.
And I'm glad that we have a GU medical oncologist in your area now.
Yeah. Yeah, I'm satisfied.
Who is that? The GU medical oncologist, the lady that we found, the Middle Eastern lady. Well, she's not really Middle Eastern. I think she's Canadian. What's her last name again?
I don't have it right now.
I'll
Her first name
put
is...
it in the chat, Rick.
Okay. Thank you, Dr. John. Thank you.
Yeah, I mean, I definitely think you have to say to her, look, can we not take a sample from something recent, because the 10-year-old stuff is probably not going to be that accurate.
Mm-hmm.
I think that would be helpful. The other thing I was going to say to you is, if you have any heart issues, we have a really good cardio-oncologist in Canada, in Ontario, in Hamilton, University of Hamilton, called Daryl Leung, who knows us really well, and he likes us.
Okay,
So
that's good to know.
Yes. So and he will definitely talk to you for if you have any issues. But he's done seminars for us, and we've tried to help him out with some studies by providing men and stuff like that. So, but he's and I've been in touch with him very recently.
Good. Thank you. Good to know. That's it for me. Yeah.
Thank you, Elaine. And we go next to Stan Friedman.
Thank you, Len. Can you hear me?
Yep.
Yes.
Great. So let me just give you a very quick background. After 3 years on enzalutamide, my PSA began to rise, and in a scan taken at about that time, they found some lesions on my right iliac bone, and went for 3 treatments of radiation. My PSA went down, and then it began to go up again about 6 months after that. So I and Dr. McHugh, interestingly enough, I have the same doctor as Kang has, we're going to look at chemo treatment. When the week before we were going to make that decision, Medicare decided to make Pluvicto available to patients without having gone through chemo. So we decided to go for the Pluvicto treatment. I took my first treatment on May 24th. My second treatment on July 2nd. So far, everything looks good. My blood levels have basically somewhat remained the same, but nothing has happened to warrant any, or nothing precipitous happened in terms of a a steep increase in a number or decrease in a number. So they're kind of remaining stable. My PSA is now zero point 0.2, and has gone down a little bit. After the first treatment, it was at 0.26. It halved from my height of 0.56. It basically halved after the first Pluvicto treatment. It's now down to 0.2 after the second treatment. I am going for a PET scan in the beginning of August. And then hopefully we'll take my third of my 6 treatments shortly after that. So that's it in a nutshell. I assume I'm going to see Dr. McHugh this Thursday. As a matter of fact, I assume that everything is remaining stable. My PET scan will obviously show whether there's any new growth or whatever, but I remain in a good place, until someone tells me otherwise.
Okay, Stan, thank you. Do they do, I think they call it SPECT CT scans right after?
Yes, they do a scan immediately after the Pluvicto treatment to
Yeah.
make sure that there's I don't know what they call it. I guess it's an engineered molecule or whatever has been distributed through the body properly, and there's no and if there's anything showing up, it's showing up where they believe that. Well, it seems to accumulate where the past lesions were, so they feel that it is attacking the right places. And so yes, but I do get a scan, short 20 minutes scan after every treatment.
Yeah. And they discuss it with you, or it's just for their purpose?
No, they usually make a comment after the 20-minute scan. Yeah.
Yeah. I think it's like a gamma counter. It picks
Yeah.
up the radiation that was just put in your body by the.
Well, they do that. They do that too. After they put it into your body, they have a Geiger counter, and they kind of move the Geiger counter away from your body to see, just how radioactive you are. And I basically can't be within 3 feet of anybody within the first 2 to 3 days. I can't be around
That's a little
pregnant
different.
people, and the normal thing. And my wife and I stay away from each other for 4 days. We have to sleep in set. Fortunately, we live in a home, so where I to live in an apartment, I'm not sure what I would do, but we have separate bedrooms and separate bathrooms, etc., for 4 days until I shed my radioactivity.
Anyone have questions? Oh, yes, we have a hand up, which is Rick. Go ahead, Rick.
So I think a discussion, given that you're pre-chemo and you don't have that much cancer, thank God, I think the discussion, if it were me, that I would be having with Dr. McHugh is, how many Pluvictos do you think I need? And the reason for that is because you've got 6 approved right now. And it may well be difficult to get additional chemo approved if you need it. We don't know yet if you can get more, but as it stands, without exceptions, you cannot. So you only have 6 in total. So you might want to think about just doing a minimal amount and keeping some in hand.
Well, you're right, Rick. I mean, McHugh discussed that with me, and as did the people in radiation, and they said that they keep it flexible. In other words, it doesn't have to be a mandated 6 weeks, 6 weeks, 6 weeks, 6 weeks. And if they think that you're doing well, they and I guess this is all new to them in a way, is that they'll move out the 6 weeks, okay, to maybe 10 weeks, between treatments or whatever. So I think your point's well taken. And one of the questions I have for McHugh is, am I doing okay? I mean, is this a stable environment where maybe I can wait 12 weeks before my next treatment, or get off the treatment until they detect whatever my PSA rising to a certain level, or whatever the case might be, where they think, okay, back to the Pluvicto again.
Yeah, I mean, to me, it's just a discussion that you need to have with him, and together you need to huddle and find out how much he thinks you need. We're in a bit of an area where we don't really know, because the approval, I believe, for the pre-chemo was with six times treatments. But there are docs right now with castrate resistant where they're holding some in the back, holding some back with much worse. Is it post chemo? I should say castrate resistant post chemo, holding some back. And yeah, you just got to huddle with him and say, I would be saying, how little do you think I need? How much can we hold back? That's how I would go in. No, how much more should we do? I would be saying, how much can I hold back, Dr. McHugh? Because I may not be able to get more if I need it later down the road.
Yeah. That's a good point. I will bring that up with him, Rick. Thanks.
Excuse me. I've got something going on. Henry West, you are up.
Hey guys, it's been a while since I've been here. I was diagnosed in 2023 at the age of 54. At that time, my cancer was already metastatic. To my abdomen and my hip and my lower back and my liver. So I underwent some radiation on my bones, and that solved my bone cancer. It was not detected after that, and I was put on ADT of abiraterone and Lupron and prednisone. After about 15 months, I was my PSA was undetectable for a few months, so my doctor and I decided to take a holiday. The holiday lasted about 7 months when my PSA started to appear and then started to double. So my MO spoke to the director of RO at my hospital, and we planned SBRT, which I had completed in March. I just had a follow-up PSMA PET scan on Friday, and I got the results today, which show that I do have disease again in my prostate, even though it was just radiated. And I also have a little bit in my abdominal lymph nodes. So I am looking for some ideas. I spoke to some very close friends who are members of this group. And I think I need to get a GUMO, which I do not have, even though I am still very happy with my MO and my RO. I just want to make sure I'm covering all my bases. And I was looking for some recommendations for a GUMO in the Westchester County, New York area, which is just outside of New York City. I've heard some names popping up, and I've been writing them down and looking them up, so I appreciate everything you guys have been talking about.
You actually had an appointment with Channing Paller in June, didn't you? Did you see her?
With who?
Dr. Channing Paller?
That's not me. No, that's not me.
That's
in
okay.
So
in Washington,
can I just go over a couple of things with you, Henry? Because I'm I'm sort of multitasking here. So you said that your disease, you were on Lupron through 524.
Yes, correct.
And was that and plus abiraterone or not?
Yes, abiraterone and Lupron.
Right, through 524. And that
Correct.
continued until when?
It stopped in 524.
Stopped in 524.
I started in January of 23, and I stopped
in January 24. Now, what is the just go over one more time the treatment you've had since 524?
Since 524, I've had no treatment other than SBRT.
And that was to where?
That was directly to the prostate.
And how much?
I don't know the answer to that question.
How many times did you go?
I had 5 treatments.
Okay. And yet you've still got prostate cancer that's recurred. When was that, by the way? What month was that?
That was in March.
And now we're seeing recurrence in the gland?
Yes.
Okay. Well, that's really weird. I mean, I just can't. I'm having trouble getting my head around that because and who was it that did the SBRT? Was it a local person?
Yes, it was in New York. He was the director. He's the director of radiology at Northern Westchester Hospital in Mount Kisco.
Yeah. I mean, you've got to get yourself, just like you're realizing, you've got to get yourself to prostate cancer specialists. It's so.
He is. That is his specialty. He actually teaches around the world about it.
Okay, well,
but he's an RO.
Yes,
he's a radiation oncologist. What's his name?
His last name is Narayana. Narayana.
Okay, now, I don't know. Has he given you any explanation as to why it's returned so quickly to the prostate?
I have not had that discussion with him. I just got the results today around noon, and I have an appointment with him on Thursday. Coincidentally, I also have a PSA test scheduled for tomorrow, which I am curious to see what's going on there.
Right. Have you had? When was the last time you had a PSMA test?
The PSMA PET scan I had in November, I think it was November or December.
Okay, so there's a couple of things here. I would be pushing for a PSMA scan again now.
I just had it on Friday.
Say that again?
I just had that on Friday, and that's the results that I got today.
Okay, so you had a PSMA test that showed recurrence in the prostate. Nowhere else?
So what it says is increased activity within the prostate, consistent with worsening disease. And then number 2 was new nodal metastatic disease above and below the diaphragm.
Okay, well, there's a couple of things. One is, I don't know what Dr. Narayana's doing, but he couldn't have blasted the whole of your prostate. And it's weird. And I would want to be getting a second opinion possibly on what's going on there. And I wouldn't go back to him for more. I would be going to, we've got our buddy Len at MSKCC Westchester, right? Muller? You're muted, Len.
I was going to suggest Henry go to Dr. O in Greenwich Hospital. Where do you live in Westchester?
Greenwich is close. I'm actually in Mahopac, so I'm in Putnam County, but I'm in Westchester all the time.
Oh yeah.
Who is Dr. O in Greenwich?
Well, hold on a minute, Len, before you go there. I'm talking about for RO first of all. I'm talking about radiation oncologist.
Oh, yeah.
Ahead of me to oncologist.
Yeah. So
Yes.
there's Boris Mihalchek in West Harrison, Westchester, probably a half hour from where you are. He's with MSK. They have a Westchester group there. He's very good.
All right. And then I definitely agree. I mean, for the best doc in your area, and that's probably where you start. I'd also agree. Dr. O's terrific. You can't get better than him.
So I assume that his name is not just what's his name?
OH.
William really? It is.
Yeah, OH. And he's at Smilo in Connecticut. He's with Yale Smilo Cancer Center, but he's not in New Haven. He's in Greenwich.
Okay, that's great.
And then I would be talking to him about where to follow up with radiation and what the heck's going on, and what was done here. Get your notes, have him look at your notes, and see if he can explain why he thinks the PSMA shows disease in your gland 2 months after you've just done 4.
No, you're right. 5. Yeah, you have the numbers right. 2 months, 3 months after, and I had 5 treatments.
It's weird. Something's not right. Either he didn't. I mean, why didn't he blast? He should have. If he gave you 5x SBRT, he should have blasted that prostate to smithereens. And if there was disease hanging around the bed or something else, he didn't go for a wide enough field.
I was definitely going to question him about that when I see him on Thursday. But I will follow up with these other 2 doctors. Can somebody drop Boris's name?
I mean, I wouldn't necessarily. I think, Len, wouldn't you start with Dr. O and let him recommend a radiation oncologist that he likes? Because you're not going to be able to mix. It's going to be hard for you to mix Memorial Sloan Kettering and Yale Smilo.
Yeah, that's a good point, Rick. Go make an appointment first with Dr. William O.H. at Yale Smilo Cancer Center in Greenwich Hospital. I'm in Mount Kisco. He's a half hour from me, and you're about 15 minutes north of me. So for you, I guess it's about 45-minute drive.
That's great.
Yeah.
Okay.
I guarantee you'll love this guy. He's really, not only is he an excellent medical oncologist, he's also just a very warm, caring human being. Very, you'll like him.
I will definitely be talking to him.
You'll love him. And the other great thing with Dr. O is he treats conservatively. He doesn't prescribe more than what you need. Right, Len?
Yeah, definitely.
And it's good to know you're in Mount Kisco, Len. Thanks.
Yeah. Been here a couple of years. I was in Connecticut before that.
So my RO was there in northern Westchester. So.
Yeah, I know. I heard you say that. I don't know anything about Northern Westchester Hospital and their expertise. I'm just too new to the area.
Okay.
I think I would feel better if Henry started some systemic treatment.
Yep.
Yeah.
It's still hormone sensitive. I mean, now developing new meds. Let's go.
But that's exactly why I think Henry's coming to us and saying, who should I go to?
Yeah.
So, we'll get him straightened out. I'm sure.
Ben has his hand up for a while now. Go ahead, Ben.
So the liver tropism and the fact that it appears to be radio resistant or might be suggests that this might be a weird variant. Do you remember anything from your pathology? Did you read it? Are you familiar with what it said?
From which pathology? From
You got a biopsy.
Okay, so when I was first diagnosed, they didn't I've never had my prostate biopsied. My initial issue presented as lymphoma in my abdomen. So they took the biopsy from the abdomen. And that's January of 23. I would have to go back and dig out that report.
Okay. Yeah, unlike Dr. E, Dr. O's name really is O. Um, okay. Well, that what's being done about your liver? That seems to me to be the most serious thing that's going on.
The liver was the initial one of the initial Mets, and that disappeared. That has not recurred. So
It disappeared as a result of
probably the ADT.
Okay, good on you.
Yeah,
Thanks.
it has not shown up again in the 2.5 years.
Great. Oh, it dodged.
Oh,
Yeah.
liver is really weird because when it shows up early like that, it's actually a good thing to have and it's easy to get rid of. When it shows up late, it's not so good. So it all depends when that liver, when the liver mets, when the timing of that liver mets.
Yeah,
is. At least that's
what I remember.
It
was not a big spot. So
yeah.
Maybe I got lucky there, or something was weird with the scan.
Yeah.
Thank you, gentlemen.
Len, if there's no one else for Henry, Dr. John and I would like to have a reprise with Allah, if that's possible, please.
I'm sorry, with who?
Alan.
Oh, yeah, sure. Go ahead. We are done. I'm done.
Oh, okay. Well, maybe we can get to Barry Yano as well, because he's been messaging me in the chat window. Because we've got 20 minutes. Oh my gosh, this doesn't happen very often. Alain, why did Dr. A decide to put you on apalutamide rather than abiraterone?
I didn't get any rationale or justification. I saw that this medication was on the list of what seems to be regularly used. So I feel kind of comfortable, but maybe you're gonna tell me something else.
Well, what we're going to tell you is this. The research shows that if you can, you're probably better off using abiraterone before apalutamide or enzalutamide or darolutamide. That's the best way. Since you've been on the apalutamide for a relatively short period, how long have you been on the apalutamide?
A month and a half.
So,
the Lupron, right? Yeah.
No, not the Lupron, the apalutamide.
Oh no, it's just 5 days.
Okay. So I would get back to her right away and say, why am I getting apalutamide and not abiraterone? If it were me, that's what I would be doing.
What would be the benefit of the
abiraterone?
Yeah.
It's considered in the trials to give you a longer initial treatment period than apalutamide or darolutamide or enzalutamide. Okay. So as long as you don't have significant heart issues and you don't have blood pressure issues.
Yeah, I do. I do have.
Okay. So yeah. So tell us more.
Well, I have a high blood pressure. It is controlled with medication, but she was actually concerned about my heart, and that's why tomorrow I'm gonna have a ACG taken.
Okay.
So that might actually be the reason why she prescribed this medication as
Yes.
opposed to the other one.
Yes. That's definitely a very valid reason. So anybody who has there's a concern over heart issues, then you wouldn't start with abiraterone. You would start with one of the what we
Okay.
call the Ide brothers.
Okay.
Dr. John, you want to add anything?
No, we're making a perfectly good guess at what her thinking might have been. I don't want Ellen to think, though, that he's on a majorly inadequate drug.
Yeah.
He's still
No,
on
no,
a he's still on a perfectly good RP.
Yep.
But nevertheless, what Rick said about the sequencing is very good. But
So
I know when I was on that drug that Rick is talking about, my blood pressure became uncontrollable even on 1, 2, 3, 4 blood pressure medications.
Oh, I see. Okay. Yeah, I definitely have high blood pressure with 3 meds. It's controlled, but who knows what would happen if I would be taking the other medication. So should I do anything? Should I talk to her about that?
No.
Okay.
I would say no, Dr. John.
Yeah, I'm happy with the current treatment plan.
Okay. Thank you, Rick, though.
There's a study of apalutamide, castrate-sensitive people, to see if it can stop them from going castrate-resistant. I know somebody who's on it, who's in that study right now, and I'm not sure if he's Elaine, are you castrate-sensitive or resistant?
No, I'm not.
Sensitive.
Okay, so that may be why she picked it, because that study has been pretty, I know, the 4 or 5 years or something has been going on, and I don't know. I know the person that I know on it is still sensitive, so he loves it.
Okay.
We were kicking around that work a few months ago among the moderators, and we're kind of taken aback by how good APA looked. Remember that, Len? I think you were in on that discussion too.
Yep.
You're muted, Len. You're muted, Len.
Sorry. Yeah, those studies showed that actually apalutamide was superior to abiraterone and enzalutamide.
But that was kind of a real world evidence study.
Yes.
Yes. There wasn't a clinical trial.
Yeah.
And I prefer Ben's take on how to sequence these ARPIs or SIs, whatever you want to call them. Like Ben says, yeah, you might be able to get a few more months if you start with abiraterone and then switch to one of the others. But if you start with darolutamide, you got a good long stretch of feeling good, even if you don't get any months after that. Whereas with Abby, you got a long stretch of hell, not hell. A lot of people don't like it at all. And then, okay, so you get a few more months with another harpy. Anyway, that's what makes it a world. Different opinions.
Definitely hell.
So, Rick, you said you wanted, what was his name, Barry?
Yeah, Barry Yano, you want to put your mic, there you go. Hello, Barry.
Hello.
Who was it that sent you to us, Mr. Yano?
I think I found you randomly on the internet.
Yeah, we're pretty random around here. Look, here's the thing. We would love to do an intake with you, and in 15 minutes, we're not going to do it. It's probably take us 20. What do you think, Len? Should we do an intake with Barry? He does have some specific questions around our good friend Eugene Kwan.
Okay, let's do it.
All right, go ahead. You demanding the hot seat.
Okay.
Well,
So
are you going to ask me questions, or am I just supposed to
no. I'm
randomly
going to ask.
provide you information?
I'm asking questions
Okay.
just to keep you in chronologic order here. Okay, so how old are you, Barry?
78.
And where do you live?
Midland, Michigan, which is about 100 miles north of Detroit.
Wow. Okay, and you're 78. When were you first diagnosed?
Last year in June.
Okay. And what was your Gleason score and PSA level at the time of diagnosis?
My PSA score was like 4,900.
Whoa.
And my Gleason, I guess I really haven't concentrated on that much, but I think I'm a +9.
Yeah. Okay. And so which doctor, well, what was your first, your primary treatment? Did you have radiation or did you have surgery?
Well, at the time, apparently on the MRI or the CT, they noted that there was probably tumor getting close to the spinal canal. And so I went through 10 doses of radiation in the lumbar cord area.
Okay.
That was my first treatment.
Okay. And what effect did that have on your PSA?
Well, within, I'd say, a month of that, I was started on docetaxel and Lupron. And I would say whenever I had a PSA determination done, I'd say it dropped maybe 20-30% every time.
They didn't put you on an androgen receptor blocker?
Well, at the time, my doctor, I guess, was probably conservative and just wanted me to be on Lupron and docetaxel. And in part because of listening to PCRI seminars and looking at some of Dr. Kwan's information, I guess I thought that triplet therapy was the way to go. And so I was put on darolutamide also.
Oh, okay. And so when did you actually begin the triple therapy?
It was probably about the second docetaxel dose by the time I finally convinced him that I really wanted to be on triplet therapy.
So like what month and year is that?
That would be probably July or August of 24.
Okay.
So
and are you still?
When did you start your chemotherapy? When did you do the radiation on the spine, and when did you start your chemotherapy?
The radiation was done in June of 24, and it was, I probably waited 2 months before I started on docetaxel and ADT.
Were you in pain? Did you have back pain? Is that why the first thing they did was radiate the spine?
No, I wasn't particularly having any back pain, although I've had, muscle spasms for years. And I probably had a spasm during that time, but it felt like they normally did. And, 3, 4, or 5 days, it'd get better. So I don't think really that the clinical signs that I was showing at the time really reflected spinal canal involvement, but based on the CT, MRI scan, they noted it and were concerned enough that they thought radiation was the first thing that I should start.
All right. And so you were seeing Dr. Eugene Kwan?
No, I've never seen Dr. Eugene Kwan. I've seen him on the internet. I go to a physician whose name is Amaruth Pala. He comes out of Appleton, Wisconsin. The hospital complex that is closest to my house and does not have full-time oncologists there, or at least they're not enough. And so either it is through periodically him visiting the site here or me meeting him on a video conference.
Barry, have you had any genetic testing?
Yes, he did that early. And I don't have the information in front of me because I didn't think that I would be discussing my situation, but I have had genetic testing.
And did anything show up that was actionable?
Well, I think what I recollect is that there were some areas where potentially I could use some additional drugs, but at this time it wasn't something that was first on the list.
Okay, so you don't recall any of the specific mutations?
No, I know it wasn't BRCA.
Okay. So did you ever have treatment to the prostate, whether radiation or surgery?
Never.
Okay. All right, so as of July or August 2024, you're on triple therapy, and so I guess 36 weeks out from there, the chemotherapy stopped, and so you're still on darolutamide and what was it?
Lupron.
Yeah,
Yes.
that's what you're on right now.
Yes.
And what's your PSA?
I just had a PSA 2 days ago, and it was 6.
Wow, that's a nice drop.
Well, I don't know. I guess looking at the literature and reviewing some of the internet stuff, they're talking about having it drop down to the 2 area within 4 to 6 months, and so I'm hanging there, and I know I started at 5,000 basically, but it has markedly dropped. I think I've had 3 PSAs within the last maybe 3 months now. 3 months ago it was 6, then it went up to 7, and I just had one, and that was back down into the 6 range again. So I really don't know what to make of that, whether I'm starting to become castration resistant or whether that is just the number bouncing around a little bit, or whether ADT is, whether ADT is potentially becoming less useful of a compound.
Well, it looks like you're becoming castrate resistant. I guess the next PSA check will tell us if it's still hanging around 6, then that's definitely castrate resistant. When is your next PSA test? How often are they doing them?
Well, usually every 3 months, but I had a PET scan done recently and went to see a radiation oncologist, and I told him, hey, it was 6 and went to 7. I think I need to start monitoring it more frequently. My oncologist had given me the opportunity probably about 4 months ago of either doing it monthly or quarterly. And previously it had been dropping significantly each time I had it. But when I had a 6 and then a 7, I'm thinking I need to go to the more frequent testing. So I'm assuming I'd probably get it in another month.
Yeah, I'm sure everyone here would agree you should push for monthly PSA checks.
Right.
And
So
let's see.
this guy Pala, did you say his name was Amaranth Pala?
Amaruth, I believe, is the spell
Amaranth.
or the way it's pronounced.
And what's
He's
the
a
last?
general oncologist.
He's a general oncologist, and his last name is Pala, P-A-L-A?
P-A-L-L-A.
L-L-A, okay. So I think what we'd really suggest is you got to get your ass to a genitourinary medical oncologist. It's interesting, you know, I was looking at the comments on our survey that Dr. John sent me this past week, and there was somebody who resented the fact that we always send people to genitourinary medical oncologists. But there's a very good reason for that. It's because the general oncologists don't do the right thing. In your case, the guy didn't put you on triplet therapy right away. He put you on doublet. That's just one thing. There's other things too. There's other things too.
Yeah, the one thing I will say is that because initially Dr. Paula was resistant to going to triplet therapy, and so there was a genital urinary oncologist in Saginaw, which is like 30 miles away, and I went there for a consult, and he also supported the idea of triplet therapy, and I basically told Paula that either I go for triplet therapy or I'm going to find another doctor, and he agreed to triplet.
Right. Well, unfortunately, you didn't get there. You're also a candidate right now to have treatment to your prostate, which Dr. Palla, P-A-L-L-A, probably has never even heard of. He would say to you, oh, you know, why are we treating your prostate? Well, we know now that after a certain period of time, it's a good idea to debulk the prostate. And that might bring your PSA down even more. So we've got to get you to a genitourinary medical oncologist. Now, probably the closest to you is in good, really good doc is in Ann Arbor. So that's an option to go to Ann Arbor. There is a guy, I don't know how far up into the peninsula he is, but we have a gent here who sees somebody who was trained by Dr. Heath, who was at Carmenos and is now over in at Mayo, and that's who we would recommend at Mayo right now is Dr. Elizabeth Heath. If you're going to see, she's fantastic. Another option is to see Dr. Shmulowitz at the University of Chicago. So you have really three options that I can think of off the top, which is either this gent whose name I will try to look up for you momentarily, who's somewhere to the north of you, Dr. Shmulowitz, or if you want to go to Rochester, Dr. Heath. If you want to travel, if you want to go down to Columbus, we've got people down there. I can't think of anybody closer than that. It's really a question of your preference.
Thomas Medica, go ahead.
Yeah, Rick, you mentioned the doctor in Ann Arbor, and there was distortion on the transmission here. So could you repeat that, please, and maybe spell his name?
Yeah, no, well, I said you could go down to Ann Arbor. I didn't mention a doctor down there because we're not really thrilled with the GU medical oncologists any longer at University of Michigan. They've got great radiation oncologists. They've got some great surgeons down there. They've got some great people if you want to do active surveillance. The guy who runs it, I think his name is Smith. He's fine, but he wouldn't be my choice. The reason why I mentioned the fellow that's up north is because I'm trying to remember who's our guy who comes in from the peninsula. Anybody help me with his name? I've got to find it, but he really likes this fellow, and he was seeing Dr. Heath at Carmenos, and she recommended this guy because she trained him, and he likes him, and I've got to just track him down right now. But I don't have a go-to GU medical oncologist for you in Ann Arbor.
And what about in Detroit, northwest of Detroit? Anything around in the Detroit
Well,
area?
no.
Nothing.
Well, I mean, there are a couple of people at Carmenos, and I've heard them speak, but I'm not super impressed with them. And you know, if we needed somewhere around there, I would drop a line to Dr. Heath and ask her who she likes in that area. If she's got anybody, she's probably trained other people who are there, and she'll give us names. But I don't have a name for you off the top. And one of the things I'd have to do is go look at Carmenos and see who's there at Carmenos right now. There is a doc who, oh yeah, there's a doc with a very long, Vashampayan, Dr. Vashampayan. She may be an option in Ann Arbor. Because Vashampian, and I'll put her name in. Hold on a minute, and I'll get it. Dr. Vashampian was at Carmenos, and then she left, and she went over to the University of Michigan, Ann Arbor. And let me see if I can find her. That might be an alternative at Vashampian. No, it's not coming up.
Rick,
Yes.
this is Beriano. I lost you for about 3 minutes. My phone ran out of power. I had to plug it in.
Sorry about that. I don't know where you lost me. I guess the question for you is, where are you willing to go for treatment?
Well, I mean, I don't have a problem driving places. I'm not, I don't know. I mean, are we talking East Coast, West Coast, or?
You have to tell me. You tell me what sort of radius you're willing to go for treatment.
Are you telling me that there's no decent prostate oncologist in the Midwest?
No, I didn't. Not saying that at all. I'm saying I just want to know what sort of distance you'd be willing to travel. 100 miles, 1,000, within 100 miles, within 500, within 1,000, within
I'd probably
3,000.
try within 500 first.
Okay, so within 500 miles, how far is it to Rochester? It's further than 500, isn't it?
You mean Rochester, Minnesota?
Yes, where Dr. Kwan is.
It's 16-hour drive, but I mean, yeah, it's probably more
Yes.
like 750, but
Right. So within 500 miles, I would probably send you to Dr. Shmulewitz at the University of Chicago. And I think he would be your best bet. And I can put that in the chat window for you. I can put his name in the chat window for you.
Okay. The suggestion I'm getting from that is that my oncologist is probably somebody you wouldn't put your life in his hands.
Well, would you put your life in his hands?
I have so far.
And have you been happy with him? I mean,
Well,
when you're having to tell him, when you're having to go somewhere else and tell him what treatment to do, Barry, how does that make you feel?
Well, I wish he would have come up with the triplet therapy initially, no doubt about it.
Okay, so I guess what we're saying is we have some concerns around that.
Okay, well, why don't you also type in there for Rochester who you'd suggest? And
Dr. Elizabeth Heath. But why would you drive to Rochester when you can drive to the University of Chicago, which is 250 miles closer?
You're
Happy to
suggesting
do it.
that both of them are equivalent, then I would go to the closer.
Yeah, both of them are equivalent.
Okay, okay.
I mean, we like Dr. Shmulewitz very much. He treats one of our board members. He treats a lot of guys. He's a great doctor. But we also like Dr. Heath, Dr. Elizabeth Heath, who used to be in Detroit very much, and she's gone over to Mayo at
Right.
Rochester. But you
Ann
won't
Arbor
get
doesn't have anybody of particular note, then I'm assuming also.
well Champion, but I can't find her. We were just talking about that when you were off the phone. There's a Dr. Champion who used to also be at Carmenos, and I think she's still there, but I'm honestly not sure. Nor can I remember how to spell her name, to be honest.
Okay.
But I've put in the chat window Russell Shmulewitz. Within 500 miles, he would be my choice. Thomas M.
Okay.
Yeah, I've got Dr. Olka Vaishampayan, Medical Oncology, Rogel Cancer Center in Ann Arbor, Michigan. The spelling of her, it's ULKA VAI.
VAI. Okay. Hold on a minute.
Okay.
I got it. So if I put in VAI, she should come right up. VAI, and I've got it. So I'll put Dr. Vaishampayan in for you as well.
Okay.
Look at them both. If it were me, I'd probably go the extra distance to Dr. Russell, but Dr. Vaishampayan is certainly should be considered.
Okay. And normally the procedure is you just call them up and tell them you want a consult?
I think you can self-refer to either of them, I believe.
Okay.
And I've put both. Do you know where the chat? Yeah, you do know where the chat window is. So you've got both options in the chat window there. Russell Shmulewitz at the University of Chicago and Ulka Vaishampayan in Ann Arbor, and both are good alternatives.
Okay.
I want to apologize also to Eric Curtis. Again, Eric, you got to be here in the first 10 minutes, man, because we will make time for you. But as you can see, we get a lot of people who want questions. And even if you come in late, it's hard to get newbies in.
No problem. No worries. I wasn't able to make the first part of the meeting, and I'm not able to actually attend Tuesday meetings because I got conflict.
Okay.
So Monday's my day.
Okay.
But I will see you next in 2 weeks.
Okay. Well, that's me, and I'll look out for you. I'll remember to look out for you, and you'll be the first up newbie, provided you're here before 10 after the hour. Is that fair?
Actually, wait. I may not actually see you in 2 weeks. I'm going to be doing the Alcatraz swim in San Francisco and spending time with my cousin. So
good for you. Okay, well, we'll try to get to you when we see you.
Cool.
Anybody want to say,
closing out?
Well, I just want to check. Does anybody want to say anything to Barry about his treatment? Any thoughts? Anybody have any comments? Okay. Back to you, Fratello.
Yeah. So Barry, get your monthly PSA checks and get to a GU medical oncologist. Those are the two takeaways for you for tonight's session.
Okay, and
Gary,
just curiosity,
Gary Peters just put his hand up. Go
Who?
ahead, Gary. Gary Peters
I
just
just
put his
had a
hand
quick
up.
question. Len, I just had a very quick question.
Yeah.
When you were referring to that real world comparison with abiraterone and apalutamide and enzalutamide, was darolutamide also in that mix that was subject
No,
to this?
no, it was not part of the comparison. I think because of at the time the trial was run or begun, darolutamide wasn't widely prescribed.
Yeah,
Okay.
and it was also sponsored by J&J. So there was an implicit bias towards apalutamide.
Uh-huh. Good to know. Thank you.
Go ahead, Barriano. You had something you wanted to ask.
well, the only thing I wanted to ask was, am I going to be shocked by what either one of these two oncologists might suggest versus the track that I've been on?
Who knows?
Okay.
They're the oncologists, not us.
Okay.
What we tell you is, and we've seen it before. I mean, people starting with very high and then going through triplet therapy and coming down. You did get onto the triplet pretty quickly, so you probably haven't missed much. The question is, how do you move forward? And one of the things that we'd be recommending you discuss with either Vaishampian or Shmulowitz is whether to debulk the primary and when to debulk the primary. That means, when do you get treatment to the actual gland itself? And right now you're probably on a treatment path that you would have finished up with anyway, but you might be coming towards the back end of that treatment path. I would also think you need another PSMA scan pretty quickly. You mentioned a PET scan. Was that PET scan a PSMA scan?
Yes, it was, and that was just like a couple weeks ago.
Okay, and where did it show cancer?
In the prostate and multiple spots along the spine.
Okay, so if that PSMA did show, there's a couple of options. One might be you might be a very good candidate to go right into Pluvicto right now.
Well, that's what the suggestion that I got from the radiation oncologist in Saginaw.
Okay, well, it's possible that they may say, okay, you've done the chemo, let's put him in Pluvicto. They may have some other thoughts, because we don't, like we said before, we want to keep that Pluvicto around for a while. They may have another trial with a radioligand therapy, either one of them that might be appropriate for you, so you can save the Pluvicto.
Yeah, actually, I was trying to talk him into Zofigo and potentially spot radiation of the prostate, but he wasn't up for that.
Okay, well, Zofigo really is a possibility, but I would do Pluvicto before I did Zofigo, and we agree with you on radiating the prostate, not spot radiation, a complete radiation of the prostate, maybe even more than that. But they've got the experts at both University of Michigan and University of Chicago to come up with the right treatment pattern.
The only thing I was concerned about with radiation is it seems like there's a pretty high incidence of side effects consisting of urinary and fecal incontinence, which doesn't sound very good.
So just come back next week and we'll talk about it with you. But a lot of us have lived with it, and it's a lot better than the alternative.
Okay, thank you.
Keep coming back. We'll write you up. You'll get the reminder. I don't know, Ben or Len, would you like to add anything to what I just said for Barry?
No, I think you nailed it, Rick. All right. Let us say good night. And who's moderating next week?
Me.
Oh, you are.
And let's see, what date is it? Oh, no, Dr. John's moderating. What am I talking about? Next week is the 29th. Yes, we've got a meeting. Guys, don't forget, we have a meeting on the 29th because we got a screwy month. See, not even I can keep up with the screwy months. So next week, Tuesday the 29th, 6 p.m. Eastern, 6 p.m. Eastern, and Dr. John will be in the hot seat. And if it runs too long, I guess I'll take over from him. Yes, Thomas M.
Yeah, Rick, I've been trying to get this information from you via email. You can just forget about that. No need to respond. What you gave me tonight is perfect. It's just it's ideal for my situation at my sister's place. So I appreciate that.
Okay, I haven't received any emails from you, Thomas.
Is that right? Okay, well, I'll have to look into that.
Okay. The last email I got from you, Thomas, was to change your email address.
Yes, I got that one right away. You know, but
okay.
Anyway, I'll check into it.
Okay.
Thank you.
All right,
Rick,
Jen.
do I need to close the recording before we exit?
Oh, if you just close everything, it'll close us all out, Len.
Oh, that's what I'll do. Ciao, ciao.
Bye-bye.
Good night.
Thank you.